All right, so let us begin. We have 3 classes on a very important and interesting topic, which is pharmacotherapy of epilepsies. Right? There are 2 terms mentioned here, epilepsy and seizures. The outline for today's lecture, which is the first lecture in the series, we will talk mainly about epilepsy, seizures, various terms, definitions, epidemiology, what is the extent of prevalence, incidence of these conditions. Then very importantly, we will try to classify the types of seizures or epilepsy. This is very important because therapy or the use of drugs is dependent on what type of seizure or the type of epilepsy that we are dealing with. Okay, anyway. We also need to understand what are the clinical signs and symptoms that we will encounter if we come across any of these seizures or epilepsies. Lastly, the last 5 to 10 minutes of the class will be taking you towards the anti-epileptic drugs or anti-seizure drugs. All right. So, few terms to introduce to you. I think a lot of these terms may already be known to you. You may not know their meanings, but here it goes. So, epilepsy, seizure, convulsion, fit, tonic, clonic, these are some of the terms that we come across. In single line, if I am to tell you about these terms, epilepsy is the tendency to have recurrent seizures. Seizure is a transient disturbance in the activity of our brain which causes certain clinical signs and symptoms. Convulsion is a particular type of manifestation of a seizure where there is muscle activity involved. There is rapid jerking movements. Fit is a very layman term. You may hear people saying in the public that this person suffers from fits. The Hindi term that we use for epilepsy is mirgi, and the attacks that we get, we call them dore ana, mirgi ke dore ana. Tonic and clonic are related to the muscle tone and the contraction that happens. We will again encounter these terms one by one. So the first thing is, try and define what is seizure. So seizure is a transient disturbance of the cerebral function due to an abnormal paroxysmal neuronal discharge in the brain that may or may not be associated with a clinical manifestation. Okay? Okay. Right. So these manifestations are basically transient occurrence of signs and symptoms. The signs and symptoms could be sensory, motor, autonomic, and they may be accompanied with by loss of consciousness, or there may be preserved consciousness. Basic issue is there is an abnormality in the electrical activity of the brain. All right. Now, this is the basic understanding and definition of a seizure. Now, what is epilepsy? Epilepsy is defined as any disorder characterized by recurrent unprovoked seizures. The important thing to remember here is recurrent and unprovoked. That means we also have a category of seizures which can be termed as provoked, which means there is an acute cause associated with it. Unprovoked, the meaning is that either we don't know the etiology of it, or the etiology is a part of a continuous process which may be related to structural or functional aspects of the brain. So it could be a CNS disease, it could be a CNS trauma due to which you are getting, let's say, meningitis, stroke, or an acute traumatic brain injury which has caused a seizure. So that seizure is a provoked seizure. It's an acute symptomatic seizure that will not count towards the diagnosis of epilepsy. We will look at this further. So epilepsy, if you want to expand the definition, it is a disorder of the brain which is characterized by an enduring or a persisting predisposition to generate epileptic seizures, and it has consequences which may be neurological, cognitive, psychological and social. So that's the broad or complete definition of epilepsy. It requires that there should be at least 2 episodes of unprovoked seizures that should be more than 24 hours apart. So that's the key diagnostic criteria for epilepsy. At least 2 seizures occurring 24 hours apart. Epilepsy as a disease, it's a heterogeneous condition. It is associated with multiple types of seizures. There may be multiple types of epileptic syndromes. Etiologies are diverse and prognosis also varies depending on the type of epilepsy. So it's like a group of disorders rather than being a single disease. Alright? Sometimes epilepsy may also be a part of a larger syndrome. So that is called as an epilepsy syndrome. So in epilepsy syndrome, other than epilepsy, there are also other characteristic clinical features. Generally, there is a typical age of onset, and till that age group, the epilepsy syndrome persists, and after that it may go away. A slightly more relaxed definition of epilepsy is that a person has one unprovoked seizure, but he or she is at high risk of having a recurrent seizure. So that risk is about 60% risk. So that is calculable based on the type of risk factors that are present in the individual. Anyone who has not had a seizure for last 10 years, or who has not been on anti-seizure medication for the last 5 years, or who has crossed the particular age group in which that epilepsy was supposed to be, can be considered as having no epilepsy. So the diagnosis is reversed, which means the person is now free of epilepsy. Any seizure which is provoked by a transient known factor like an acute illness or a medical condition or electrolyte disturbance or any such thing in an otherwise normal brain, which means there are no structural functional disorders or disease in the brain. So this temporary transient factor has led to the lowering of seizure threshold. This does not count towards the diagnosis of epilepsy. So this is a provoked seizure. This is an acute symptomatic seizure, reflex seizure, right? It's due to an acute transient disturbance. It's unlikely that this may happen again because that particular condition may not happen again, right? So you need to understand epilepsy, seizure, the differentiation. Next is etiology of epilepsy. What can be the possible causes of a person having epilepsy? Hereditary or genetic causes are very well established. Only 1 or 2% of epilepsies are known to have single gene defects. Most of the epilepsies which have hereditary component are known to be associated with multiple gene defects. Head trauma is a very well known cause of development of epilepsy. So the more severe the trauma, the greater are the chances of a person developing epilepsy. So someone who has a mild head trauma has a 2 times higher risk than a normal individual to develop epilepsy, whereas someone who has severe head trauma is likely to have 7 to 10 times higher risk of developing epilepsy compared to a normal person. Then structural diseases in the brain like brain tumors. 30% of brain tumors are associated with epilepsy, and this is particularly the case with temporal lobe tumors. Then conditions like stroke could be hemorrhagic stroke or ischemic stroke. Inflammation in the central nervous system, which could be related to immune pathways, so there could be autoimmune encephalitis, or it could be related to infections like HSV, herpes simplex encephalitis. Then systemic infections as well as infections having CNS manifestations. So problems like HIV, neurocysticercosis, very well known to be associated, onchocerciasis, malaria, tuberculosis, they can all lead to development of epilepsy. Then metabolic causes along with electrolyte disturbances which are persistent due to some disorders of metabolism, maternal injuries during childbirth, trauma during childbirth, right, hypoxia during childbirth, this could also lead to future development of epilepsy. Besides all these causes, a lot of epilepsy still cannot be associated with any particular cause. So that is called as unknown etiology, or the previous term used was cryptogenic epilepsy. All right. Stimuli. Stimuli not for epilepsy but for having seizures. In 5 to 10% of individuals, exposure to particular or specific stimuli can lead to precipitation of seizures. Those stimuli could be visual stimuli, it could be auditory stimuli, it could be something like excessive thinking or taking stress, mental stress, sometimes excessive eating, listening to loud music, reading, sudden exposure to hot water, startled, which means getting suddenly, provoking a startling response. Somatosensory proprioceptive sensations can also sometimes serve as stimuli. How do we clinically diagnose epilepsy? So, there is a clinical manifestation which has happened and you need to ascertain whether this is seizure and whether this can further be diagnosed as an epilepsy. So, a very detailed clinical history is the key to identifying whether that particular event is in fact a seizure, what could be the possible cause of that, whether something like this has happened earlier, or whether based on the current risk factors of the individual, this is likely to happen again, which means you could actually classify that individual as having epilepsy. So, generally 3 classical phases are associated in the whole occurrence of a seizure. So, there is something called as a pre-ictal phase. Pre-ictal phase is characterized by presence of something called as an aura. An aura is something like a warning. So, this warning could be in the form of motor or sensory symptoms. It could be in the form of a sensation of fear, anxiety. It could be in the form of discomfort in the stomach. So, this could be aura. So, this is just a warning that maybe an epileptic seizure is likely to happen. Next is the actual seizure event or the ictal event. Ictus is the seizure event. So, this manifests in the form of unilateral or bilateral tonic-clonic movements. Sometimes there may be sudden jerking of the body, there may be deviation of the eyes and head, alteration or loss of consciousness. Because of all of these things happening, there may be injuries, issues like tongue biting or urinary incontinence, sometimes fecal incontinence also. This can all happen as a part of the seizure. So, pre-ictal, ictal, and what could be the third phase? Post-ictal. So, after the seizure has happened, there may be a short phase where the patient may have confusion, may experience fatigue, disorientation, dizziness, drowsiness, headache. All of these things may happen. Generally, this post-ictal phase, it lasts for a few minutes. In rare cases, it may persist for a few hours. But please remember that these are classical phases of a seizure. It's not necessary that these phases may happen in every individual who has seizures or who has epilepsy. Okay? Another thing to remember right here is, everyone who is diagnosed with epilepsy will definitely have seizures, but everyone who has a seizure is not necessarily having epilepsy. Got it? So, this is a very significant thing to remember. Okay. Now, there is an international organization called ILAE. It stands for International League Against Epilepsy. So, this is an international scientific body. In 2017, they revised the classification of seizures and thereby the classification of epilepsy. So they have a framework within which they basically classify at 3 levels. What are those 3 levels? Seizure type, then epilepsy type, and finally, does it belong to an epilepsy syndrome? Seizure type, these terms are very important. So the 2 main types of seizures and accordingly the 2 main types of epilepsies are focal and generalized. Those which cannot be put in either category is basically unknown when we don't have a good history or a verifiable history. According to the type of seizures being suffered by the individual, recurrent seizures, the epilepsy could also be focal, generalized, or there could be a combination of both generalized and focal. And those for which we don't know, they are unknown. If these epilepsies are then associated with certain other types of clinical presentations, then they belong to some kind of epilepsy syndromes. So that is the 3-level classification framework suggested by International League Against Epilepsy. ये जो terms है focal and generalized, do they make any sense to you? When we say focal and generalized in relation to seizures or epilepsy, what focal or generalized portion are we talking about? It is in the brain, cortical activity of the brain. So if it is localized in a particular focal area, you get what we have, focal seizures. If the abnormal activity is throughout the brain, then it is generalized. Okay? So the manifestations will differ and we will look at the manifestations later. Now, generalized seizures can be further classified into motor and non-motor, which means the manifestations are either motor dominant or non-motor. Similarly, focal seizures may also be classified depending on whether, along with those localized or focal seizures, is there a loss of awareness or consciousness, or is it preserved? All right? Now, we look at the major classification. So there are 3 main categories of seizures according to the ILE seizure classification. Why these categories are important? Because once you know that a seizure has happened in a particular person, you have to identify based on the presentation which type of seizure it is. Because the choice of the drug depends on the type of seizure. Because each seizure type is associated with some abnormal electrical event. Based on that, you are likely that one particular type of drug will be more effective in one type of seizure and the other type of drug will be more effective in some other type of seizure. So this is very important to understand. So perhaps the most commonly seen seizures are focal seizures, which were earlier also known as partial seizures. So this term has now been withdrawn, partial has been withdrawn. Now the term which is used is focal seizures. And these focal seizures can be without loss of consciousness. So in olden times, in our textbooks, we used to read them as simple partial seizures. And the same focal seizures could also be with loss of consciousness. In that case, the old term which was used was complex partial seizures. In some of your textbooks, you may still find these terms. But the current terms are focal seizures with loss of consciousness and focal seizures without loss of consciousness. All right? There are also focal seizures which get secondarily generalized to generalized tonic-clonic type of seizures. So this is a seizure which starts as a focal seizure but then evolves to become a generalized seizure. All right. Then you come to generalized seizures. Generalized seizures, as I mentioned in the previous slides, can have motor dominant manifestations. In that case, they are called as tonic-clonic seizures or GTCS. GTCS stands for generalized tonic-clonic seizures. The old name used for these type of seizures was grand mal epilepsy, whereas absence seizures, the typical absence seizures are non-motor type, where there are no or very little motor manifestations, but generally there are only sensory manifestations. So this was also called as petit mal epilepsy. These are the typical absence seizures. There are also a variety called as atypical absence seizures. Other than these two main varieties of generalized seizures, you have generalized seizures which are myoclonic, clonic, tonic, atonic. Depending on muscle contractions, rigidity of muscles, loss of tone of muscles. Okay. Genesis. So this is basically a very simple diagrammatic representation of how the electrical activity is in generalized seizure. Can you appreciate here? The entire brain, all of the brain, all parts of the brain is affected. Okay, and the person is generally unconscious or has loss of awareness. Whereas in focal seizures, one particular area of the brain, one lobe of the brain or part of the lobe of the brain may be affected. So depending on the type of or the area of the brain affected, you may have, agar frontal cortex involved hai, what would you have? What type of manifestations? Motor or sensory? Frontal cortex. You will have motor manifestations. If you have parietal cortex affected, you will have sensory manifestations. Similarly, you could have autonomic manifestations. So this is how generally the seizure activity kind of spreads out. So here you can see there is a typical focus from where the seizure activity is only going to a localized area, whereas here the focus is somewhere centrally located and the seizure activity is going through the entire cortex of the brain. Okay. Then any seizure which cannot be classified into the previous two categories, which is focal seizures and generalized seizures, we can call them as unclassified epileptic seizures, where we do not have inadequate data or which we are unable to classify in the previous category. So that is unclassified epileptic seizures. What could these be? Some of the most common seizures actually belong to this category. Febrile seizures, as the name suggests, seizures which appear when fever comes, and these are more common in children. Then you have another variety common in infants called as epileptic infantile spasms, also called as hips arrhythmias. So these are brief sustained contractions of proximal muscles. They are generally flexor in nature and they may involve both the upper limbs and the lower limbs. Then you have certain syndromes. I talked to you about syndromes where you have epilepsy as well as other clinical features. So there are some very well known syndromes, and these syndromes could be both generalized and focal. So one is juvenile myoclonic epilepsy. In fact, this is the most common epilepsy syndrome. Juvenile, you can understand the age group with which it affects, and the manifestations are myoclonic. So there is a clonic contraction of the muscles. Okay. Then there is Lennox-Gastaut. Then there is Dravet syndrome, West syndrome. Lennox-Gastaut happens in children who are between 3 to 10 years of age. It has multiple etiologies associated with it, whereas Dravet syndrome has a single gene defect and it occurs in younger children. So each syndrome has a typical age group of onset and in which they occur, and they have a constellation of symptoms which occur along with the epileptic seizures. These are the key signs and symptoms. If we look at focal seizures without loss of consciousness, what are you likely to see? So you may see, if motor cortex is involved, you may see involuntary repetitive movements happening suddenly. If the sensory cortex is involved, you may have paresthesias, abnormal sensations being perceived. If visual cortex is involved, you may have sensations like flashing light phenomena. The person experiences as if lights are continuously flashing. So that's actually a seizure happening in the individual. If it spreads to ipsilateral regions within the cortex, same side regions within the cortex, it's like a progression of the seizure activity. So this is sometimes called as Jacksonian march. So the motor seizures may start somewhere in the upper limb, go up right up to the shoulders, and then may extend to the trunk, may extend to the lower limbs. So that's called a Jacksonian march. Then what about focal seizures with loss of consciousness? So this happens typically when the temporal lobe is affected, when structures like amygdala, hippocampus are affected, or sometimes the frontal lobe is affected. Here, generally the patient will have an aura or a pre-ictal phase before the seizure happens. Involuntary automatisms are a characteristic feature of these type of focal seizures with loss of consciousness. So this automatism could be in the form of simple repetitive movements like smacking of the lips, hand wringing, driving, playing instruments. So that activity becomes repetitive and it is involuntary. The patient doesn't realize and cannot control the activity which is happening repetitively. There may also be focal seizures with secondary generalization, which means the seizures start as focal seizures, but they become generalized. They involve the entire body. So here they evolve into a tonic-clonic seizure with a sustained contraction, which is a tonic phase, followed by rhythmic movements, which is the clonic phase, contraction alternating with periods of relaxation. So can you imagine this? Suddenly all the muscles go absolutely taut and then they start shaking vigorously. So there is a contraction relaxation which happens. So that's the classical generalized tonic-clonic seizure. If you may have seen dramatic visualizations in movies or any such, maybe a series, web series, or on the internet, these are the type of seizures that you are likely to see, where the patient, the entire body goes into convulsions. There is rigidity followed by contraction, relaxation, jhatke jo aate hain. So that is your generalized tonic-clonic. So it may start focally and become generalized. Now what about generalized seizures? So you have the tonic-clonic, that's what we were talking about, and there is an abrupt onset of this, and generally it is accompanied with loss of consciousness. Okay, so this is characteristic of generalized seizure. There is loss of consciousness. The patient becomes unconscious. So this generalized tonic-clonic seizure is also called as grand mal epilepsy. Symptoms we have already discussed. This is a lot of times accompanied by phenomena such as teeth grinding, teeth biting, frothing from the mouth, झाग निकलने लगता है मुंह के आसपास, urination, defecation, which means there is incontinence, and a loud cry, and the person suddenly falls. So because of the fall, the person may injure themselves very severely. So these are classical generalized tonic-clonic seizures. Now what about the second major category, which is absence seizure? They happen more in children. They are also called as petit mal epilepsy. Here there is a sudden brief interruption of consciousness. There is no motor manifestation generally. What will happen is suddenly there is a blank staring and cessation of all ongoing activity. So half of this I can see in many faces here. Blank staring. Cessation of activity does not happen. But in an absence seizure, there is a blank stare, and then suddenly after a few seconds, the normal activity resumes. This happens with children in their school, and their school teachers may complain to the parents that your child is not attentive in the class. Suddenly your child will go off somewhere, loses focus, and then suddenly he will be back in the class. So actually the child may be suffering from absence seizures. Okay. Then myoclonic, where very brief, a second or even less than a second, shock-like contractions of the muscles may happen, which may be restricted to some extremity, or it may be generalized through all the extremities. So it's very quick, happens very quick. So it is missed a lot of times. Then what about the other terms like tonic? Tonic matlab there is increased tone. So this is sustained contraction of muscles, right? Can be flexion, can be extension, can be both. Then the next thing is atonic. What will happen in atonic? What do you think will happen in atonic seizures? Sudden loss of tone. There is no tone. Right now, as you are sitting here, which muscles are helping you stay upright? Mainly your back muscles, isn't it? Do you think there is tone in those muscles? If there was no tone in your muscles, what would happen? You would fall down. So atonic seizures, the person loses the tone in their skeletal muscles suddenly, and because of that they may have a sudden fall. Then you have clonic. You read about GTCS. What is GTCS? Generalized tonic clonic. So there is a tonic phase and a clonic phase. Sometimes the patient may only have the clonic phase where there is repeated jerking of the muscles. There is no tightening or rigidity of the muscle. Sometimes the patient may have aura, I have already talked to you about, so this is a generic term for a warning. Sometimes there may be convulsions. Convulsions are nothing but another term used for violent spasmodic contractions of muscles. So clonic phase is what we call as convulsions. The clonic phase many a times is accompanied by tonic phases. Sometimes only tonic may be there, sometimes only clonic may be there. The classical is both tonic and clonic being there. So generalized tonic clonic seizures, but there may be generalized tonic seizures, there may be generalized clonic seizures, there may be generalized atonic seizures. All of the presentations are possible. Okay. Then we come to a term called status epilepticus. Have you come across the term status asthmaticus? Okay. What is the current definition of status asthmaticus? Or what is the definition that you know of status asthmaticus? Anybody? Status, when you apply this term before a condition, it means that it's a continuously present condition. Status asthmaticus, earlier we used to read that there are 2 episodes without recovery in between or incomplete recovery in between. Now status asthmaticus, it's basically defined as an acute severe attack of asthma. Let's come to status epilepticus. What do you think would be happening in status epilepticus? In simple terms, it is a prolonged seizure state. Generally, a seizure is supposed to happen over a few minutes, and then the seizure activity is supposed to stop. The person is then supposed to recover. But what if the seizure activity persists for a long period of time? What will that cause? Seizure activity persisting for a long period of time, what will that cause? What do you think? It will cause long-term brain damage, complications, right? So let's try to see what is the definition of status epilepticus. So it is an epileptic seizure that is sufficiently prolonged or repeated at sufficiently brief intervals so as to produce an unvarying and enduring epileptic condition. This is a scientific definition of status epilepticus. And if we try to dilute it down, what it would simply mean is repeated seizures without recovery in between. Right? So these repeated seizures could be of any type, could be generalized, could be focal, there could be motor manifestations, there could be non-motor manifestations. So accordingly, you may sometimes call them as convulsive status epilepticus or non-convulsive status epilepticus. These are recognized terms. Convulsive and non-convulsive status epilepticus. Now, is there something missing here in the definition? We are saying that for a sufficiently prolonged time or at sufficiently quick intervals. What is this time? What is considered as a prolonged time? By definition, it is 30 minutes. How many minutes? 30 minutes. But there is a lot of evidence now which says that 30 minutes is impractical. You cannot wait till 30 minutes to diagnose a patient as having status epilepticus and start appropriate treatment. Any seizure which persists beyond 5 minutes needs to be practically considered as a status epilepticus, and emergency management needs to be given to such patients for status epilepticus. Okay? Right, let's repeat. आप बताओगे लास्ट रो में इधर? Yes, you. What is the time duration that we just discussed about status epilepticus? 30 minutes. And practically, how many minutes should we wait before starting treatment for status epilepticus? आप बताओगे? अलंकार? ठीक है, बैठो. Both of you please come and meet me in the department once we finish this lecture. Okay, next. So this is treated as a medical emergency, and you would be surprised to know that this is actually one of the it is not actually one of the rare things which happens. People who have epilepsies, people who do not have epilepsies, they also turn up with status epilepticus states in the emergency departments. So this is very important, this 30 minutes ideal time and the 5-minute time. Why this is important is anyone who has a status epilepticus needs immediate medical attention, immediate medical therapy. Parenteral therapy is recommended with drugs like ones which we have already studied, benzodiazepines, intravenous lorazepam, intravenous diazepam are the drugs of choice to start management of status epilepticus. Please write this down. This we will discuss in detail in one of the subsequent classes, but this is one of the questions which comes. Management of status epilepticus. Okay, so you need to know what is status epilepticus, and then only you can start management for it, right? Next, we are now living in an era where we are very lucky that we have drugs available for almost all important medical conditions, and very good drugs available. Similarly, for epilepsy also, therapy has significantly changed. So this is an excerpt from a German textbook way back in 1796, which mentioned the management of epilepsy as this: give the sick person some blood from a pregnant donkey to drink, or steep linen in it, dry it, pour alcohol onto it and administer this. This was the standard treatment for people having seizures or epilepsy 200 years back. Okay, so how far we have come? So we will start with a little bit of history of before history. Let's have a look at the cellular mechanisms behind seizure generation. If you understand this, you will automatically remember the basic mechanism of action of anti-epileptic or anti-seizure drug. Okay, so we are continuously talking about seizures, and we are saying that seizures are basically due to an abnormal or excessive electrical activity in the brain. What could lead to this abnormal or excessive electrical activity in the brain? Some very basic phenomena that could happen are too much excitation. What could be involved in too much excitation? Yes, excitatory neurotransmitters like glutamate, aspartate. What else? Neuronal excitability is executed by depolarization, which happens due to which channels? Sodium channels. So, flow of ions through sodium or calcium channels. What about too little inhibition? Either there is too much excitation or there is too little inhibition. Inhibition of the, we have inhibitory mechanisms in our brain to stop excessive electrical activity. So what if those inhibitory mechanisms have become weak or that activity is too little? So what will be involved here? Which neurotransmitter would be involved here? GABA. So too little or reduced activity of GABA, which is the main inhibitory neurotransmitter. Other than that, there is a special role of a particular type of calcium channels. So you have read about calcium channel blockers, right? Drugs like nifedipine, amlodipine, felodipine, nicardipine, nimodipine, which are dihydropyridine calcium channel blockers. Then you have non-DHPs also. Drugs like verapamil, diltiazem. Which type of calcium channels do they block? Yes? L-type calcium channels. L-type calcium channels are specifically present mainly on the blood vessels and on the heart. But there is another variety of calcium channels called as T-type calcium channels. T-type because they execute the thalamic current in the brain. So that's why they are called as T-type. So those T-type calcium channels are also involved in inhibitory activity. So sodium calcium currents, excitatory neurotransmitters like glutamate, aspartate, inhibitory neurotransmitter GABA, chloride ion channel, outward potassium currents. These are what we focus on when we talk about the drugs used for seizures. So you will see that most of the drugs which are used as anti-seizure drugs or anti-epileptic drugs, they will act on one of these structures or one of these pathways. All right. So these are the major mechanisms. The most important mechanism is inhibition of use-dependent sodium channels. Majority of the broad spectrum anti-epileptic drugs have this mechanism of action, which is inhibiting sodium channels. Okay. So by inhibiting the sodium channels, they prolong the inactivated state of the sodium channels, which prevents the excitability from getting transmitted. Then next is enhancement of GABAergic action. So GABA action कैसे enhance हो सकता है? You already know some of the drugs. Tell me the drugs which enhance GABA action. Benzodiazepines and barbiturates, you already know these drugs. But other than these classical drugs, you have now got a whole list of drugs which act on other aspects of GABA. Some will increase synthesis of GABA, some will increase release of GABA, some will inhibit breakdown or degradation of GABA. So in every possible manner, increasing the GABA activity. So that is the second main mechanism of action. Then inhibition of glutamate mediated excitation through antagonism of receptors which are NMDA and AMPA receptors. So some of the newer anti-epileptic drugs are acting through this mechanism. Finally, inhibition of the T-type calcium channels which are responsible for carrying the thalamic currents. So this is specific for absence seizures. Please write it down. T-type calcium currents are specific for or specific in the pathogenesis of which type of seizures? Which seizures? Absence seizures. So any drug which you want to use for absence seizures has to have what mechanism of action? Inhibition of T-type calcium channels. Any drug which cannot inhibit T-type calcium channels will not be effective for absence seizures. So you have only a few drugs available which act through the T-type calcium channels, right? So this is a diagrammatic representation or a graphic for sodium ion channels. Okay, so this is the lipid bilayer, this is the activation gate, there is an inactivation gate. So this is what state of the sodium channel? This is the open state where both activation and inactivation gates are open. What will happen here? So this is the channel, the pore which is there in between. So you will have sodium which will easily be able to traverse through this. So go from outside the cell to inside the cell. Okay. Now, what if in the same channel the inactivation gate is now closed? So this becomes the inactivated state of the sodium channel. Now what will happen? The same sodium cannot traverse through. So this is the inactivated channel, right? So the mechanism of action of anti-epileptic drugs which act on this channel is to enhance or prolong this inactivated state of the sodium channel, which does not allow sodium to traverse through the channel pores. Okay. So which are these drugs? This is your first introduction to the drugs. You may have heard some of the names of these drugs. So all the classical anti-epileptic drugs, your phenytoin, carbamazepine, valproate, lamotrigine, topiramate, they are all acting through blocking or prolonging the inactivated state of sodium channels. If you go and look at pharmacotherapy of epilepsies in any center, 80 to 90% of the epilepsies or seizures will be treated with these drugs itself. If you are asked for naming some anti-epileptic drugs, these are 5 drugs that you are most definitely expected to utter. Phenytoin, carbamazepine, valproate or valproic acid, lamotrigine, topiramate. Okay. Now, another major mechanism is through increasing the GABA transmission or increasing the activity of GABA. Now have a look at it. What is this? Lipid bilayer mein which receptor is this? In the last class only we discussed this in so much detail. What is the name of the receptor? GABA, benzodiazepine, chloride, channel receptor complex. Alright. It has a binding site for benzodiazepine, its partial agonist. What is its partial agonist? Beta carboline. And what is its antagonist? Flumazenil. So it has binding sites for all of them. It has a separate binding site for drugs like phenobarbital, which is a barbiturate. It has a separate binding site for GABA itself, right? So this is one site of action and these are the drugs which act through it. Also drugs like topiramate, felbamate may act through the GABA site of this particular receptor channel complex. Then you have certain other drugs which act on other parts of the GABA pathway. Gabapentin helps in synthesis and release of GABA. Vigabatrin, it acts on GABA transaminase. Then valproate, which was also having mechanism of action of sodium channel blocking, also acts through another enzyme called semialdehyde dehydrogenase, which basically breaks down GABA. Then you have a drug called tiagabin, which inhibits the reuptake of GABA through its transporter called GAT1. GAT1 is nothing but GABA transporter. So you have drugs increasing the synthesis, drugs inhibiting the degradation, drugs inhibiting the reuptake. All of that is there. Now one very important thing to write down and note here itself is this drug sodium valproate or valproic acid, it comes as a salt, so that's why sodium valproate. It is the broadest spectrum anti-epileptic drug. Reason is that it has all possible mechanisms of action. It inhibits sodium channels, it has effect on GABAergic pathway, it also has antagonistic action on glutamate pathway, and it is also एन इनहिबिटर ऑफ द एब्सेंट सीजर के लिए कौन से चैनल्स हैं? टी टाइप कैल्शियम चैनल्स. So all the possible mechanisms valproate has. So that's why valproate is one drug which can be used for all types of seizures. All types of seizures. Cardiovascular system has been taught to you. Yes or no? Yes. Like valproate, recall that antiarrhythmic drug which has all class activity and can be used for all types of arrhythmias. Yes, correct. It's amiodarone. Amiodarone has sodium channel blocking, potassium channel blocking, calcium channel blocking, right? It has some beta blocker activity also. So similarly you have valproate, and along with valproate, write this down also. So valproate is the classical anti-epileptic drug which has all types of mechanisms of action. Among the newer anti-epileptics, the recently discovered anti-epileptics, lamotrigine also has all types of mechanisms of action. कौन सी? Lamotrigine. Okay. All right. So we end today's class here. If you have any questions, please let me know. So in the next class, we will take up each important anti-epileptic drug from the newer or classical group as well as the recently discovered group.